If you understand the anatomy of the hand, and you understand how everything is supposed to work, it would just help make it easier. And then when you understand fractures, then you can take what you know and understand about fractures and then be able to apply it to all areas of the arm in terms of fractures. If you understand surgeries and the types of surgeries don't necessarily change. But what changes are the one that they pick based on the area. But it's all on like hand fractures and dislocations, therapist management of, and surgeries, like surgical managements of. And this is key because you're gonna see it come up time and time again in all different types of cases, right? Bones are bones. Bones are bones. Bones are bones, right? So you're gonna have your intra-articular types of fractures, and then you're gonna have your extra-articular fractures. If we're just looking at fractures, there's really two types of fractures. There's the fractures that are inside the bone. And this is something I do too. I take a complex word, I translate it into an easy word, and then because I am able to translate it into an easy word, I can then translate it into a complex word. So if you're not familiar to seeing some of this word, this is why it's important to do a certain amount of reading, and reading in the sense that you can skim over the chapters as you're reviewing, so you can catch the words and how they use it. And you don't have to like recall it and quiz yourself necessarily, but you want to be able to understand and be able to be able to translate. Like I always, when I think about anatomical position, I still sometimes put my arms out because all of this is volar. And so when you see the chapters and you're reading in a one-dimensional way. And you see these graphs and you're like, oh, apex, dorsal, and volar, and you're like, oh God, what is that? If you just put your hand out and you say this is volar and this is dorsal, that now you've added a visual component and a tactile component, kinesthetic component. Thank God we have our hands, right? For the most part, we have our hands. And these, believe it or not, this is our cheat sheet. Don't tell them. It might make you take it off, right? Put it outside. So inside the bone is extra-articular. I used to be so confused about this because it just didn't make any sense, right? Intra-articular, inside the joint. Inside the joint. And this is outside the joint. You can remember me, I'm extra. I'm outside of the joint. So intra and extra-articular. So the reason why you want to kind of always keep these things in mind is because extra-articular types of fractures tend to be quote-unquote easier. Intra-articular is less predictable. It's less predictable. Why? Because structurally you've gone now and broken inside the joint. You've broken inside that articular cartilage. And so now the congruency of your joint may be lost. That's why it makes it harder. It might have been dislocated. So anytime you have a fracture, it's one thing, but when you have a fracture and dislocation, you just like compounded your problem, right? But really what it comes down to a lot is the stability and the congruency of the joint to be able to move. And that's what makes it less predictable, harder to treat. And if it's bad enough, you're gonna need surgery. And then you have to think about like, why, what type of surgery would you have? So it goes back to the evaluation, right? It goes back to the evaluation. Now you kind of know a little bit of the general information. You go back to the evaluation, you think about the date of injury, the date of surgery, where exactly, very specifically, is the fracture? Was it delayed? Or soft tissue issues a problem? Are there capsular tightness? Is the tendon gliding? All that stuff, right? And then you think about the prognosis. What are they allowed to do? When? Based on stability, based on complexities. So that's how when you start to think about fractures, you gotta build up like using the evaluation, using the prognosis, and then being able to get into treatment, right? So in terms of surgeries, right? So if you have fractures, what kind of surgery would you have? So there's several different types of surgeries. I think there's there's 5 of them that they really, talk about in terms of fracture fixation. The surgeries are done to increase stability, right? And then to get alignment. And alignment isn't just in one direction or another. It might be a rotational deformity. So surgery is going to help to stabilize, align, and fix any kind of rotational deformities. And one of the most common ones that you'll see is wire fixation. And it's actually Weyers-Kirschner. It's good for fractures that require minimum soft tissue problems, bony exposures. It's used with loop tension bands. So you might have intra-articular type of fracture where they need to distract from the joint a little bit, and especially in the fingers, they're gonna do K-wires, and then they're gonna put rubber bands to distract the joint a little bit. Those are called loop tension bands. Have a wire loop, which is used for compression of a fracture site, but anything wire specific, it could be just a simple wire like pins, where you'll see most of the time you'll see a minimum of 2 to stabilize a fracture, right? And then it might be a 3, but K-wires or Kirschner wire fixations are the weakest fixation. It is the most common in fingers. But remember when I said that you can use this knowledge to compound what you know? And it's because pretty much this is for any kind of fracture you're gonna run into in the arm, right? But you'll see most of them in the fingers just because the size is so small. And then the next type of fixation you're gonna see are screws. So screws, start thinking about in the screws, you might see it for like a bigger bone, right? Because P1, they wouldn't necessarily put screws in P2 or P3 just because of the fact that they're such small bones, but P1 might be able to sustain a screw or 2. Screws can often be seen in wrist fractures as well. One common one is a scaphoid fracture. You'll see a screw go through there. And then you have ORIFs. So ORIFs, open reduction internal fixation. So you see plates and screws. So just think about where would you see plates and screws. You can see them in P1 fractures. You can see them essentially sometimes in P2 fractures, but very rarely, just because the structures make for complications due to our skin and tendons that adhere down. So doing an ORIF up here can cause problems. Where else can you see fixations like that? Oh, you can see them in the metacarpals. Where can you see? They're too big, plates and screws, so you would never see them in carpal fractures, right? You would only see them use plates and screws if they were doing a fusion to stop all movement because it's so big and these wrist bones are so small. You would see them in distal radius fractures, you would see them in forearm fractures, you see them in elbow fractures, shoulder fractures, right? So you just kind of think about where you've seen them and how they would just be able to be applied to so many different areas. Intramedullary fixation. Intramedullary fixation. And that's going to be like that rod placement. And you don't necessarily see a bunch of these. You might see that in the shoulder if it's a humerus fracture, but really it's not often used in the hand. It might be, but they tend to be just like a straight down nail. And if they did that and you've seen them in the, it's actually done as pins, K-wires, versus the that type of fixation because they tend to leave those fixations in, they don't remove them. Whereas pins, you put them in for 4 to 6 weeks and then you pull them out, right? And then the fifth one is external fixators. External fixators, they tend to be used when all else cannot stabilize and fix the problem and provides temporary distractions of the fracture site. Unfortunately, I've seen it in small fingers for P2 types of fractures, and they're terrible. They don't do well. But it's usually because it's so fragmented, and the bone is so small that you have intra and extra because it's I mean, it's just completely crushed, you know? And I've seen them where they're trying to provide the stability, but the hardware itself is just so heavy. And even with splinting, it just can't really hold everything together. And, you know, bone fractures need to be essentially reduced to be as close as possible. I'm about to go into some fractures and how to really think about it. So it comes down to foundational knowledge, right? So let's say this is, let me see, this is your metacarpal. This is P1, P2, and then P3, right? If you're looking like this is volar, right? And then on the back is dorsal. So on the back, you can't see the extensor mechanism, but you know it's there, right? And then on the front side, you have your volar plate, and your volar plate, right? Volar plate of the MP, volar plate of the PIP, and of course the DIP has a volar plate too. And then you have your tendons, right? Then you have your superficialis, and then you have your profundus, right? So they kind of just run right around the same area. And then you have your collateral ligaments, right? You have your collateral ligaments. Here's the thing with collateral ligaments. So in the PIP, they're always taut. They're always tight, both in flexion and extension. That's how I draw flexion and extension. PIP, they're always tight, right? You know, collateral ligaments in the MP are a little bit different. There are two parts to it. It's the true and the accessory. I think I was looking at like a really old note, and they were saying that, I think it was, there's another word for proper, also known, AKA proper. If you haven't seen it, it's okay. It's in the 7th edition. They call it the true and then the accessory, right? But it's essentially, it's a collateral ligament, but the collateral ligament of the MP has two parts. And the reason why it's important is because instead of like the PIP and the DIP where they're tight in both flexion and extension, the true is loose in extension and tight in flexion. Tight in flexion, loose in extension, right? And so, if you know, you might understand that the MPs always need to be in a safe position of between, you know, 60 and 80 degrees, right? To kind of, you know, protect the MPs from being stuck in extension. You might know that, but the why behind that is because of the collateral ligaments. The true portion being tight in flexion and being loose in extension. Now, why would you want them to be tight in flexion? Because in a way it doesn't make sense, right? Because you're putting them into a safe position so they wouldn't get tight. And you're right, it won't get tight if it's in flexion, because the true collateral ligament, when it's in flexion, it has to go around this big old metacarpal head. And the metacarpal head puts stress on, like stretches it out to keep it loose, even though it is tight in flexion. Does that make sense? I think that's the best I've ever explained it. Somebody tell me that it makes sense to them, right? So that's why anytime anything happens to the MPs, you think, how I need to put them in here, it's because of the true collateral ligament, right? Now you might have a question where it's just talking about collateral ligaments, but if they break it down into true and accessory, which sometimes are assholes and they do that, right? You know it's the true that is tight in flexion and loose in extension. The accessory part of the collateral ligament is attached to the volar plate. Remember the volar plate? So the volar plate, when it goes into flexion, slides down proximally. So when you go into flexion, it's supposed to slide down proximally, right? Dude, this is what I do. Distal, proximal. Distal, proximal. Like, it will help you make sense of stuff, and then it slows you down on the exam. You get that visual and kinesthetic understanding, okay? So the accessory, you go into flexion, the volar plate goes and moves proximally, right? Well, because the accessory portion of the collateral ligament is attached to the volar plate, it will also move proximally, so it will stay nice and loose. And that's why MPs need to be placed in a safe position of between 60 and 80 degrees, right? Does that make sense? There's also these structures, a volar, and this is now just being really finicky and picky, but you have you have your extensor mechanism on the back of the fingers. You have a dorsal capsule, right? And then on the volar part, you have what's called a fibrous digital sheath. Fibrous digital sheath. It's just the same thing, just in a different location. So they call it a fibrous digital sheath. What do you think a dorsal capsule is? Dorsal is in the back of the hand. Capsule is just fibrous sheath, right? But when you think about all the structures that are there, how it can play a role in why a finger doesn't move after a fracture, after a dislocation, why there's no glide in the tendons, why the joints get so stiff, right? And then you're gonna have your ulnar side and you have your radial side. So when you start seeing radial, and ulnar collateral ligaments, the radial and ulnar is just for location, just like the dorsal and volar. It's just for location, so you understand.